Good morning. Thank you, Dr. Sunny, for that introduction. And I would like to thank the organizers of this wonderful conference for inviting me to be a part. Okay, so I'll be talking about interesting cases in pediatric endocrinology. So basically, I'll present 3 cases, which are different presentations of the same clinical condition, and I'll give a brief overview of the topic. So my first case, it's a term baby boy who was born by cesarean section with a birth weight of 2.7 kilos and born to a gravida 3 para 2 mother with 2 previous children who are fit and well. The baby was noted to have a micropenis measuring 1.8 centimeters, phallus with a thin shaft. Both the testes were palpable, but were slightly higher in the scrotum, and the scrotum itself was quite small. So the baby had respiratory distress, transient tachypnea, and required neonatal intensive care support and was on high flow nasal cannula oxygen. So I apologize for the poor quality of the picture, but this is how the genitalia look like. So at 1 hour of life, the blood sugar dropped to 26 milligrams per deciliter. So the baby was started on IV fluids, after which the blood glucose normalized. And once the respiratory distress settled, the baby was started on feeds. At this point, the blood glucose dropped again as the fluids were being reduced and the feeds were being increased. So the baby was managed by addition of Duocal to the feeds and was gradually weaned off the IV fluids. So during the time of hypoglycemia, baby had a hypoglycemia screen done, so which showed an adequately suppressed insulin. So this ruled out any hyperinsulinism. So the cortisol done was quite low. So as you probably are all aware, during hypoglycemia, you should have a robust increase in counter-regulatory hormones, and you would expect the cortisol to be much higher than this. So the cortisol was low, as I mentioned. The electrolytes were normal. So this ruled out any salt-losing condition like mineralocorticoid deficiency. Thyroid function done showed a low free T4 and an inappropriately normal TSH. So normally if the T4 is low, you would expect the TSH to be higher, but here it was normal. And pediatric endocrinology consultation was requested in view of the micropenis and the low cortisol level. And a presumptive diagnosis of multiple pituitary hormone deficiency was made. So thyroid function tests were repeated again, and the picture was similar. So low T4 and a normal TSH. Baseline gonadotrophins were done. These showed a low FSH and low LH and a low testosterone. So babies usually have what is called a mini puberty. So after the first week of life, the gonadotrophins go high, and there is an increased testosterone in boys and increased estradiol in girls. And this mini puberty lasts for around 6 months in boys and can last for around 2 years in girls. The ACTH was low, and the baby had a low normal prolactin. So ACTH stimulation test was performed. So you give synthetic ACTH and you do cortisol at 30 and 60 minutes. And to call it a pass, you need a cortisol response of more than 500 nanomoles per liter. So here you can see the baby had a quite low baseline, and there was no increment at 30 or 60 minutes. The baby also had jaundice with increase in direct bilirubin and neonatal hepatitis picture with increase in liver enzymes. So with this diagnosis of multiple pituitary hormone deficiency, MRI was done. And what you can see here is a very small cella turcica with a very small pituitary gland. You would expect to see a pituitary stalk here, which is absent. And the posterior pituitary bright spot, which should be here, is quite high up near the optic chiasma. So ophthalmology review was obtained, and this is important to rule out any optic nerve hypoplasia or septo-optic dysplasia. So this was normal. And LHRH stimulation test was done to confirm the diagnosis of hypogonadotrophic hypogonadism. And as you can see, there was no increment in the FSH or LH levels after giving LHRH. So this baby has ACTH, FSH, LH, TSH, and possibly growth hormone deficiencies. And the baby was started on hydrocortisone in 3 divided doses initially, and then subsequently started on thyroxine as well. And I'll speak about this later as to why hydrocortisone is started first. The parents were given sick day management plan, and they were also trained on using injection hydrocortisone intramuscular in case of crisis. And subsequent follow-up was arranged with neonatology and pediatric endocrinology. The baby continued to have prolonged neonatal jaundice, which slowly settled. The baby was given 3 doses of intramuscular testosterone for 3 months. And at follow-up, the T4 normalized and the TSH is quite suppressed as is expected. So normally, before you start treatment, they have a normal or slightly high TSH, but when you give thyroxine, the TSH levels become very suppressed. So you cannot monitor the treatment response by monitoring the TSH. You need to monitor the free T4 only in these patients. And the liver function normalized completely. So this is the appearance of the genitalia after the testosterone injections. So at present, the baby is 2 years old. The height has dropped to the 0.4 centile, and the baby has a low IGF-1. He's developmentally normal, except for mild speech delay, and I plan to start him on growth hormone. So as you can see, recently there has been a plateauing of the weight, and his height has dropped, and his height is well below the mid-parental height. The second case, I saw initially at the age of 3.5 months, and he was referred again for evaluation of micropenis and an abnormal thyroid function. He also had a prolonged jaundice and had seen a pediatric gastroenterologist. So he was born at term, was SGA with a birth weight of 2.4 kilograms, again had respiratory distress with a mixed acidosis picture, and required NICU care for around 5 days and had a lot of problems, including asymptomatic hypoglycemia. So the baby had a few investigations done for the prolonged jaundice and was diagnosed as ESBL, E. coli urinary tract infections, and had 7 days or so of meropenem. So on examination, he had significant failure to thrive. The weight was well below the 0.4 centile. Some subtle dysmorphism was noted, like frontal bossing, mid-face crowding. He looked jaundiced, had a small phallus, bilateral undescended testes, and a hypoplastic scrotum, and the impression was of multiple pituitary hormone deficiency. So these investigations were done before I saw him. As you can see, he has a neonatal hepatitis picture with conjugated hyperbilirubinemia. The jaundice had improved slightly by around 3 months, but there was increase in his ALT, AST, and gamma GT. The gamma GT was normal first, and this is actually described in ACTH deficiency, that they usually initially have an ALT and AST, which is high, and a normal gamma GT. He also had low free T4 on 2 occasions with a normal TSH. So a baseline pituitary profile was done, and this showed a low IGF-1, acceptable cortisol. We did an ACTH stimulation test, which again showed a very flat cortisol response, and an LHRH stimulation test, there was no increment at all. So the MRI brain shows an omega-shaped cella with a very small pituitary gland. The stalk wasn't seen. I went through the images with the radiologist. We couldn't see the bright spot, but clinically the baby does not have a diabetes insipidus picture. So this baby has ACTH, growth hormone, FSH, LH, TSH, and likely growth hormone deficiencies. Again, management has been similar to that of the other baby with hydrocortisone injection training, thyroxine later, and testosterone. I don't have any pictures before or after treatment. So this blood test was done 2 weeks after starting treatment. As you can see, there has been considerable improvement and the liver functions have normalized now. But just in 2 weeks, there was drop in total bilirubin, direct bilirubin, there was improvement in liver enzymes, and the FT4 is better. So at present, he's 20 months old, developmentally normal. He has bilateral undescended testis. Sorry, 1 second. I think you've loaded my previous talk. It's fine, it's okay. So he has bilateral undescended testis. The MRI did not could not locate the testis. And he had an HCG stimulation test done. This was to see if there was any functioning testicular tissue. So as you can see, there is an increase in testosterone. So there is definitely some functioning testicular tissue. He needs surgery, but parents are dragging their feet. He's got a low IGF-1. His height is, he's growing okay. His height is on the 9th centile, which is slightly below the mid-parental height, and he may need growth hormone treatment. So this is when I saw him first. As you can see, his weight was well below the 0.4th centile, but after starting treatment with the hydrocortisone and thyroxine, the weight has picked up, though recently it has plateaued. My next case is that of an 8-month-old boy who was referred by his pediatrician for abnormal thyroid function. So he was seen initially for poor weight gain. He had good birth weight of 4 kilos, was feeding well, developmentally normal, and had a low TSH, but free T4 was not done. So as you can see, his weight was on the 2nd centile. His genitalia was normal. He was on iron supplements. Celiac disease had been ruled out. So the diagnosis at this point was secondary hypothyroidism, and to rule out deficiency of other pituitary hormones. And I plan to assess his baseline pituitary profile. So this was the initial TSH, which was low, but there was no T4 done. And this often happens that sometimes, I mean, in the adult world, they don't seem to do the T4. So some pediatricians also do not do. Yeah, sorry. Do not do that, but remember that we can have secondary hypothyroidism with a normal TSH. So this case, if the TSH wasn't noted to be low, this diagnosis would have been missed completely. So I repeated the thyroid function, and this is because sometimes you can have transient abnormalities in the thyroid function. So I repeated it, and the T4 was low with a normal TSH this time. And then I again repeated in another 2 weeks' time, and the free T4 was still low, and the TSH was normal. So looking at the other pituitary hormones, he has a low prolactin, a low IGF-1 with a Z score of -2.4, normal cortisol response on ACTH stimulation test, and his MRI was normal. So he has deficiencies of TSH, prolactin, likely growth hormone, but has a normal ACTH. So he was started on thyroxine, and the dose has gone up as is expected in line with the growth. And now his weight after treatment has gone up to the 50th centile. Though he has a low IGF-1, he's still growing normally. Well, he was with a height on the 75th centile, though recently it has dropped to the 50th centile. So this is his growth chart. As you can see, the weight was here, then it dipped, and this is where I saw him. And then after treatment, it has started picking up, or it picked up. And his height, despite the low IGF-1, was here, though recently it has dropped. So a bit about pituitary hormones. So the anterior pituitary has the acidophilic and the basophilic cells. The acidophilic cells, the somatotrophs, produce growth hormone. The lactotrophs produce prolactin. And the basophils, the corticotrophs mainly make the ACTH, thyrotrophs, the TSH, and gonadotrophs, the FSH and LH. So the pituitary is under regulation by the hypothalamus, which makes both stimulatory and inhibitory factors. I'm not going into the details, I'm sure you all know. So the incidence of hypopituitarism is around 1 in 4,000 to 1 in 10,000. The incidence of isolated growth hormone deficiency is more than the incidence of multiple pituitary hormone deficiency. And as you saw, the presentation can be quite non-specific, and the presentations is usually because of hormone deficiency. So as we saw in the first two patients, micropenis, prolonged jaundice. Now, prolonged jaundice may be either cholestatic because of ACTH deficiency, or it may be unconjugated because of the TSH deficiency. And quite often you can have a mixed picture. Neonatal hypoglycemia, and some of them can have extra endocrine features, so midline defects. So if you have a midline cleft palate or a single central incisor, it is important to assess their pituitary functions. They may also have septo-optic dysplasia, anophthalmia or microphthalmia, optic nerve hypoplasia, holoprosencephaly. And in certain genetic mutations, you can have like a spine abnormality and limited neck rotation. So genetic mutations may be seen more commonly in familial cases, and the frequency of mutations is low in sporadic cases. And usually if you have deficiency of GH1, growth hormone gene, or the growth hormone releasing hormone receptor gene, you may have isolated growth hormone deficiency. If you have transcription factor mutation, you can have varying combinations of multiple pituitary hormone deficiencies. So this is a developmental cascade of genes involved in pituitary development. So HESX1 and SOX2 are involved more proximally, and HESX1 especially is implicated in septo-optic dysplasia. And then downstream you have other genes like LHX3 and LHX4, and various other genes like the PUF1 and PROP1. So I apologize, the slide is quite busy and I'm not going through all of them, but I'll just describe the phenotype in a few. PUF1 is associated with multiple anterior pituitary hormone deficiency. So is PROP1, and the PROP1, there are some of these patients may later on have hyperplasia of the anterior pituitary. LHX3 can have cervical spine abnormality, as I mentioned, and LHX4 cerebellar abnormalities. And SOX2 and OTX2 can be associated with ocular abnormalities. So in one particular study from Italy, they found that around 13% had mostly mutations in these 5 genes. And if you have mutations in these genes, they are more responsible for causing familial multiple pituitary hormone deficiency. Again, in Europe, the mutation seen more is the PROP1, but this is less common in Asians. And if you look at cases with multiple pituitary hormone deficiency, growth hormone deficiency is seen in all, and gonadotrophin and TSH deficiency is in around 80%, ACTH deficiency in around more than 50%, and diabetes insipidus is seen less commonly. And when you look at the imaging, you can see abnormalities of the hypothalamus or pituitary in around more than 80% of the cases, which may be either hypoplasia of the pituitary gland, ectopic posterior pituitary, or an interrupted stalk, as we saw in the MRI images of our patient. If you have septo-optic dysplasia, you may have absent corpus callosum or septum pellucidum, and then you can have other abnormalities like optic nerve hypoplasia, schizencephaly, etc. So the management, most important is the patient education, hormone replacement of the hormones which are lacking, so hydrocortisone, thyroid hormone replacement, growth hormone. So sex hormone replacement, so initially testosterone may have a role to improve the appearance of the phallus, and these children will need hormonal replacement to take them through puberty. They will need fertility treatment. And if you have diabetes insipidus, then desmopressin. And as I said, there may be a role for testosterone in the newborn period. So the important points in the management, you should start hydrocortisone first before starting thyroxine. This is because both TSH and ACTH deficiencies can have a inappropriate ADH presentation-like picture, so they cause fluid retention. Also, when you start thyroxine first, it can increase the clearance of the cortisol. So you can tip them into adrenal insufficiency if you start thyroxine first. So you start hydrocortisone first and then start thyroxine after 1 or 2 days. And hydrocortisone replacement may unmask any pre-existing diabetes insipidus. So if you have ACTH deficiency, this masks the presence of DI, again, because of the fluid retention. So when you start hydrocortisone, they start clearing the free water. So this may unmask the DI. So this is something to be aware of. And the treatment dose of hydrocortisone is around 10 to 12 milligram per meter squared, and we give it in 3 divided doses. And just to be aware that infants or newborns, and especially if they have cholestasis, they need initially much higher dose of hydrocortisone and thyroxine because of their poor absorption. And again, this is very important to be aware of. It's very important that these patients, the parents be educated in sick day management. So if the patient is very unwell, has only mild intercurrent illness, but is well, is afebrile, or has only like minor falls, cuts, bruises, there is no need to increase the hydrocortisone. You just continue with the normal dose. If they're moderately unwell with a temperature more than 38 or having any vomiting, diarrhea, or any moderate injury like fractures, etc., then you double the largest daily dose of hydrocortisone and you give it 3 times a day. So for example, if a patient is on, say, 5 milligram, 2.5 milligrams. So the largest dose is the 5, so you double it. So you can give 10 milligram 3 times a day and you give it till the patient is better. If the patient is unwell, they can't tolerate the oral medications or is unconscious, then this is where the parents need to give the intramuscular hydrocortisone and take them to the emergency as soon as possible. If they are unresponsive or vomiting, check their renal function, electrolytes, and blood sugar, treat hypoglycemia, fluid resuscitation. And if there is a delay in obtaining a cannula, then give them an IM hydrocortisone. Otherwise, start them on intravenous hydrocortisone, either as an infusion or you can give it as 6-hourly bolus. And when the patient is better, then you put them on oral, but give them double dose for, say, 2 to 3 days. And again, this is something which everybody needs to know, that if there is any surgery, they need stress dosing. So they need hydrocortisone injection at induction. And also this needs to be continued till the patient is better and can take orally. So to conclude, hypopituitarism is rare, but it's something to be aware of. It's an important clinical concern. Pediatricians need to be aware or alert to the diagnosis. And it's very important to be aware of the sick day treatment in any child on steroid treatment. Thank you.